I'll stop. I can, yeah, not too bad. I'm literally just trying to start my webinar, but I think because there's this chemistry class going on, I've been like logged out, so I'm not too sure how I can start it. I'll just check our message, okay? Yeah, okay. Perfect. So just wait just a couple more minutes to let everyone in and then just start straight away. So hopefully you can hear me all okay. Perfect. Right, brilliant. Okay. So I'm going to get started now. So hi everyone, my name's Shivam. It's really, really good to see a lot of you back this week. So the whole point of today really is to go through and talk a bit about medical ethics. So it's a topic that is definitely going to be coming up in the medical school interviews, whether that be panel or MMIs. And in terms of medical ethics in particular, the reason why it's becoming even more prominent is that the biggest exam that you'll take as a medical student in the future is actually the SJT exam, so the situational judgment exam, and that exam basically tells you where you rank really in the UK in terms of all the medical students and the likelihood of you going to certain deaneries or certain places in the UK when you pick your jobs. So the SJT is such an important exam, and what it really encompasses is medical ethics. And again, that's why they like to talk about it so much, and that's why they like to include it in the interview so much, because it's going to be such an important part of your career really. So if we just jump straight into it, again, anyone who hasn't got the QR code for the WhatsApp group chat, then you can take a screenshot and just go onto this when you can. Just waiting for a few more people to join as well. There we go. Perfect. So I think really the key part of medical ethics really comes down to the Hippocratic Oath, which comes all the way back to kind of Greek times, and such a long time ago that this was kind of really talked about. And the key part of the Hippocratic Oath really is it's the oath of ethics, and really the part that they're trying to get at here is that I will do my best to ensure that patients receive the best quality care. They are treated with respect. They are treated with dignity. And that essentially sums up the Hippocratic Oath. And it is something that sometimes interviewers like to ask you about. So I would recommend just understanding kind of the 3 or 4 lines that are involved in the Hippocratic Oath. But if I was to sum it up, it would be the fact that patients, that doctors are have to have patients at the heart of everything, and that they must respect their patients and basically do their best to ensure that patients kind of have their dignity and are treated in the best way possible. And it's still something that when you graduate is something that you kind of almost kind of sign that oath. So in terms of ethics themselves, I think it really comes down to these 4 pillars of medical ethics. Now, this is something that you may have heard so many times before, but I just have to clarify the importance of it again and again. And I just want everyone to really understand what the 4 really mean. So what I will do to begin with is if anyone can just put their hand up, and I'll just pick someone at random who can just really talk about the first 2, so autonomy and beneficence, so what they mean, and if they can think of some examples. So yeah, so Aurora, I'll just unmute you. I don't know if you can do it yourself, but if you can give it a go.
Yeah, can you hear me?
Yeah, perfect.
Yeah, so autonomy is ensuring that patients, they have the choice in regards to their treatment, and beneficence is kind of putting patients' best interests. However, I just want to add on to the autonomy point is sometimes doctors, they can is it overrule? I don't know if that's a word, but overrule overall patient's autonomy depending on the situation.
So what situations might that be? Can you think of an example, or can you think about what doctors have to kind of assess in patients before they kind of make a decision for them?
I feel like it can be related to like capacity and like the competence of the patient. So I don't know if this is relevant to this point, but maybe Gillick's competence, and if the patient is underage, they don't really have the choice whether or not they should go ahead with the treatment. It's the doctor's choice in that case to ensure that it's for the patient's best interest.
Yeah, unless you deemed them to be Gillick competent. So really that this kind of follow-up question for you then, Aurora, is how do you then assess someone's capacity or someone's competency? How do you do that as a doctor? And it doesn't matter if you don't know, you can kind of guess as well. You can kind of think of maybe some phrases you might ask the patient.
So I think for consent, you can give like oral consent or written consent. So maybe if it's just like a small procedure, doctors can like do oral consent for the patient. However, if it's for a more complex procedure such as operations, the patient may have to give written consent. And
Yeah.
then,
So really, Aurora, what you're talking about here is slightly, it's talking about consent, which is really understanding if they can. I feel like you're almost there, Aurora. So in terms of consent relating to capacity, so how do you think a doctor might check that someone has capacity? So Khadija mentioned in the chat about understanding. So how do you check that someone has understanding?
maybe just like ensuring that they understand what the actual, for example, the treatment is, ensuring that the patient understands the benefits and the risks of the treatment that they're given, and understanding what the procedure actually like contains.
Yeah, no, absolutely. And really, Aurora, the best way to remember this, and this is really a tip for everyone, is in terms of capacity, the best way to remember it is almost think about how information flows into your brain and then out through your mouth. So it's really, can someone, first of all, understand the information? So again, think about that information kind of going into their ears. Can they understand it? Can they then process that information? So thinking of kind of that information going into their brain. And then another part of processing is also balancing. So think about like a weighing scale, really. Can they balance the kind of pros and cons of what you're talking about? And then can they verbally tell you and verbally kind of communicate with you? So if I then ask, is it Levi or Levi? In terms of, and if I relate something to a vaccine, so if I'm trying to assess someone's kind of capacity to consent to having a vaccine, based on what I talked about in terms of information going through kind of the ears, being processed in the brain and then communicated, can you kind of give an example with regards to that then?
So you could wait, I don't know if, can you hear me?
Yeah, I can hear you very well.
So you would like let them know of the pros and cons of the vaccination. So you're let them know about like the beneficence and the non-maleficence side of it. So you're letting them know about the information. So whether or not they if they take the vaccination, they'll be protected against because they'll create an immune response. So they'll be protected if they ever come into instance with this pathogen again. But also there's if they are able to like regurgitate and not like kind of tell you back the kind of side effects as well, and then being able to like weigh out the pros and the cons of that. I'm not quite sure.
Yeah, no, you're absolutely right. And to be honest, we can do a bit of role playing in this scenario, to be honest, and I can kind of be the doctor in this situation. And is it Levi? Sorry, is that how I pronounce the name?
Yeah.
Yep, Levi. So here in this situation, Levi, let's say you're the patient. So if I kind of I've told you kind of my name and I've kind of confirmed your name, date of birth as well. And really what the kind of first question that I would say to you, Levi, is kind of, do you know much about a vaccine itself? Do you know what a vaccine is? So again, how would you respond to that? I mean, you can, in terms of like a scenario.
Okay, so I'll be like, I know it's like it could either be like mRNA or it could be a dead form of a pathogen or the antigens, which then your body creates an immune response and remembers the specific antibodies that are required to create the immune response if you come into terms of, if your body comes into contact with the pathogen again.
Yeah, absolutely. So Levi, is it something that you've had before? Have you had a vaccine in the past?
Yeah.
Yeah.
COVID.
Yeah, nice. So already, Levi, just by asking you kind of one or two questions, already my understanding of your understanding is very great. I can see that, oh, well, you actually know what a vaccine is and how it really works. So already and you've been able to communicate that back to me. So already you basically, by doing a very quick assessment of your capacity, you have capacity. But again, just to double check and ensure, I would give you all the information about what a vaccine is. I'd also say that there are some side effects of a vaccine. So some of them might be, for example, today you might feel a bit unwell, you might have flu-like symptoms. And if you do experience anything like that, then or anything worse than that, then you can get back in contact with us. So Levi, I know I've mentioned a few bits and bobs about what a vaccine is. Do you mind kind of telling me a bit about what you know then and why you're going to have a vaccine today?
So I know that it will protect me if I come to contact with the pathogen again. So it may not, I may still experience symptoms of the illness, but it will mean that I am more protected if I come into instance with the pathogen again. But also I know that my body may also cause, the antigens may also cause a quite rapid and like immune response, which could be dangerous to my body, such as like fever or like an allergic, like a reaction, which could be quite fatal almost. I don't know.
Yeah, no, absolutely. And again, I would just clarify a few things in terms of, so with a vaccine, you're not 100% protected when you get a vaccine. But what a vaccine means is if you do get infected by that disease, then your body will basically have a heightened response, and there's less chance of you getting serious symptoms that might even hospitalize yourself. So Levi, does that kind of make sense? What we've just done there is a kind of a role play scenario in terms of assessing someone's capacity. Now, Levi, do you assume that adults have capacity?
Yeah, I think doctors, you assume that adults have capacity.
Yeah, absolutely. So anyone kind of 16, 18 years or older, you assume that they have capacity. Now, the area or the grey area is really when patients are under 16. Now, when patients are under 16, that's where we have to actually assess their capacity. And what we do is exactly what we've just done there. So we tell them some information about the procedure or about the situation at hand. And we talk about kind of the pros and cons, and we get them to think about the pros and cons and process that information, and then get them to communicate that back to you. And that really essentially summarizes what capacity or competency is. So does that make sense, Levi?
Yeah, that makes sense. Yeah. Thank you.
Lovely. So that sums up really this case of where patients have autonomy. Of course they do, but sometimes if they don't have capacity, and they're not competent, then actually doctors can make decisions in their best interest, which is why it kind of flows into beneficence here, or best interest. And again, really, really, really easy to remember, because beneficence, it kind of looks a bit like benefit. So that's how I like to remember it. It's something to benefit the patient. And again, it begins with BE, so I think about best interest. So yeah, Gayatri, did you have a question? Sorry.
You were on about autonomy and how a doctor could overrule it. What if the patient interest has, let's say, a partner or a child who could make a decision? If it's not something the doctor would advise, could the partner or child or whatever overrule the doctor's decision either way because they have capacity?
So in this situation, who is the patient? Who is the kind of guardian, for example? Sorry, I was just a bit confused.
Say like the patient's an old man with Alzheimer's, but his wife, who's slightly younger, maybe let's say 50, 60, and she has capacity to make decisions, and the doctor wants to perform a surgery on this man, but she doesn't want it, and she understands everything that the doctor's saying, but she refuses to. Obviously, the doctor would want the patient's best interest. Would they still be able to override the wife's decision, or like what else would happen? Yeah,
so really, really good question. And to be honest, this kind of is a scenario that happens all the time, really, in hospitals. And to summarize the answer to that question is, first of all, remember the patient is at the center of all the decisions that you make. And remember, capacity and competency is all time dependent, and it's decision specific. So for example, someone with Alzheimer's disease, in the morning, they could wake up in the morning and you could ask them, what would you like to have for breakfast today? We have Oatabix or porridge or something, and they might be able to make that decision at that time. And at that minute and at that period and at that particular question, they actually have capacity and they have competency. So that's the first thing, Gayatri, in terms of a question like that. So everything is very time specific and situation dependent. Now, if this person is unable to kind of talk back or understand what is going on, then we have to think about if there's anything in writing. So have they written down anywhere that they didn't want to have particular procedures, or that they did want to have particular procedures? And then another thing that we need to take into consideration is who this person's power of attorney is. And who is basically responsible for their decisions. So sometimes patients have, but what patients do just before, when they start getting quite ill, is they can actually transfer their kind of decision making to someone else. So that might be a wife or husband, or that might be a child, for example. So that's why I can't quite answer the question very explicitly, Gayatri, because it all is very situation dependent. But does that help?
Yeah, thank you.
Yeah. And again, in the interview, they're not expecting you to kind of give a very explicit, definitive answer. What they're asking you to do is to think about all these scenarios and all these situations. And actually, as a doctor, what would you be thinking about? Because at the end of the day, family is very, very important, and you need to be respectful to family. But at the end of the day, it's the patient's decision. And if they don't have capacity, then actually doctors need to start thinking about beneficence and non-maleficence, and whether we override a decision or whether we do something for the best interest. Okay. So this, no worries at all. And this third point, the third kind of pillar really of non-maleficence is really doing no harm. And I think this is a really, really interesting one. Again, can anyone put their hand up, or put in the chat, if anyone can put some examples of non-maleficence? So can you think of any examples of non-maleficence or any scenarios that might involve non-maleficence? So non-maleficence meaning do no harm. So I think medication is an absolutely brilliant one. And the reason why it's a brilliant one is because every single medication that we give patients has some sort of side effect. And really, every medication that we give, it's this balancing act, isn't it? You know, we are putting something into someone's body, and it could have a potential side effect. So what we're thinking about is, if we give a patient paracetamol, ibuprofen, or aspirin, we're still always thinking about the disadvantages. So particularly something like ibuprofen is actually potentially quite a dangerous medication to give to a lot of elderly patients. It causes bleeding of the stomach sometimes. And actually, even then, you know, we really have to think about all the medicines that we give. So another example of non-maleficence, again, a lot of people talking about kind of cancer in terms of undergoing surgery and survival. I think another example that I could think of is if someone needs an organ transplant, okay, well, let's say we have an organ that we can give to this patient. Well, actually, we could give it to them, but there's a chance that it could be rejected, or there's a chance that it could be the complete opposite blood group or completely different blood group, and that would be harming the patient. So even though you think you're doing something to benefit the patient, actually you'll be doing more harm to the patient. So it's a really nice topic to be able to talk about with the interviewer, because it's really this balancing act of what can we do to benefit the patient versus what are we doing to potentially harm the patient. And it's something to always discuss with the interviewer. Always think about both sides of the argument. And again, I'll ask people if they can raise their hand for this final one. So justice. So what does justice mean, and why is that also such an important ethical principle? So yeah, Madison, do you want to answer this question?
Yeah, hello. I think justice often relates to sort of like big picture medicine when you think of the NHS as a whole, because it's often used for making decisions about like distribution of healthcare. When you have some operations that might be really expensive, but could that money be spent elsewhere to sort of like help problems that are more preventative? So that sort of thing. Making sure that you're not discriminating against any groups, whether that be like class or race and things like that.
Yeah, absolutely. So really, these autonomy, beneficence, and non-maleficence are very independent, kind of one patient specific. But like you said, Madison, justice is really thinking about the community. It's thinking about everyone in society and the allocation of resources. You're also thinking about the legal aspects. So thinking about, you know, are certain things law abiding? So again, if I ask a question in the group chat, so can anyone think of examples where you have to break confidentiality and tell someone else something, or raise it to the police, for example? So yeah, things to do with kind of STIs, terrorism, absolutely. And then one to do with cars. Can anyone think of that? Anything to do with cars? Yeah. Yeah, so anything to do with kind of road traffic accidents. So you have to inform the DVLA with regards to that. So why is that? Well, if you think about it, if someone's been in a car accident, there could be other people involved. There could be other people at risk. Is this person, did they crash because they have a medical condition that is going to potentially make it difficult for them to drive in the future and put other people in danger? And that's really, I think that really encompasses kind of justice. So justice, think about the community, think about all the other people that doctors are trying to treat, and the allocation of resources. So yeah, Shrina, did you have a question?
Yeah, I was just going to say, could you also say for justice that it's about providing free and equal treatment to like the whole population? Everyone gets the same quality of care, and that's why the NHS is so important, because it's a guaranteed medical care and treatment for everyone.
So I think, Shrina, that really, I think, encompasses more of the kind of NHS principle. So that NHS principle is really what you mentioned there. I think justice, it is very, very similar to what you're talking about, but justice is really thinking about allocation of resources and also thinking about the community in general. So what are we doing to benefit patients overall in our community? So do you see the slight distinction, Shrina, there between the two?
Yeah, so that's more relating then, not necessarily about the actual treatment the patients receive, but more so kind of how you're distributing that treatment within society and within the allocation.
Exactly. And the key NHS principle is that everyone should have access to healthcare, and it should be free at the point of care. So, Shrina, do you see that this might be different for example, in America, where, yes, of course, in America, they use the 4 ethical principles, but healthcare is not free at the point of care, like it is in the NHS. So that's the distinction.
Yeah. Okay. Thank you.
No worries. And Charmy, did you have a question?
Yes. Can you hear me?
Yeah, I can hear you well.
Okay. I wanted to ask, in some situations that the patient might come and tell you that, please don't disclose this to anybody, or maybe they're involved in something illegal. Do you still break the confidentiality and tell the police, or do you keep treating them without telling the police?
So again, Charmy, really to answer that question is it's all situation dependent, and it really depends on what has been done, what the person has done. But I think it's really important as future medical students and as future doctors that we don't think about breaking confidentiality straight away in scenarios. That's actually a really important point. We should, as doctors, we have a duty to treat the patient's healthcare problem at this moment in time. So they could have actually done something illegal. They could have done something quite bad, terrible in your eyes. But actually, at this moment in time, you need to help them to treat their medical problem. And then if you feel like this needs to be escalated, so for example, if it's harming a third party, if there's a third party at risk, if it's potentially relating to something like terrorism related, if it's relating to road traffic accident, then these are the situations that you start thinking about, okay, maybe we should start escalating this to someone else, or we need to inform someone else about that. And again, another big point that you need to tell the interviewer as well is, if you ever do break confidentiality, what do you need to do before you break confidentiality? So Charmy, you can answer this, or in the chat as well. Make it people can answer.
Maybe ask permission from the patient. Like, is it okay if I tell this person about a particular thing?
So close, Charmy, but very, very close. But I think most people in the chat have kind of answered the question in terms of informing the patient. So just telling them that actually, unfortunately, I will need to break confidentiality today. And if they get very angry or they don't want you to, then that's a different story. You still need to tell them, actually, I do appreciate that this is something that you didn't want me to break in terms of this confidentiality, but actually I'm doing this for a particular reason. So again, I think the key take-home point from today is that every case and every situation and every individual in society is unique, and every case that doctors deal with is unique in some respect. And that's why we need to answer these questions in the interview in a very open way, and we need to think about both sides of the argument. So before we break confidentiality, we should always think about, actually, can we ask patients particular questions, or can we raise particular topics with the patient? So for example, if we go back to a scenario with sexually transmitted infections, before we even come close to breaking confidentiality, we need to ask that person, is there a particular reason why you haven't told your partner about this, or why you haven't told someone about this at all, and trying to explore it in a bit more detail? So Charmy, does that make sense?
Yes, it helps. Thank you.
Yeah, perfect. And Aurora, did you have another question about that at all?
Yeah, I just had a question about say you had a depressed patient who came, and for example, say he was underage, and you needed to like break his confidentiality, and then tell his parents, but the depressed patient like reacted really negatively to it and said he was gonna like suicide or something. How like what would you like actually do in that scenario?
So again, so you've got a scenario where you've got a patient who's depressed, and are you saying to them you would like to break confidentiality? Is that what you're saying?
Yeah, but then the patient might have reacted and said something along the lines of, "Oh, if you like tell my parents, then I'm gonna like do suicide or something."
Yeah. So I think really, Aurora, it's actually that the fact that the doctor would probably never even talk about breaking confidentiality in a situation like this. So if you've got a patient who comes to you and is depressed, you need to obviously, like I said before, treat the patient in this moment in time, explore their feelings and thoughts and why they you can ask them, have you told anyone about this? Because they might have told friends but might not have told family or their parents, for example.
Yeah.
So you're really exploring this in a bit more detail, and if you feel like this person is imminently in danger, so literally as soon as they step out of the room, they are in imminent danger of harming themselves or harming someone else, then you would think about considering breaking confidentiality. But if you think about it, Aurora, there are thousands and thousands of patients that are suffering from mental health conditions in the UK, but that doesn't mean that doctors break confidentiality on a daily basis or in thousands. There's always a very, very particular reason for breaking confidentiality, and that's when you feel like someone else needs to know about this very, very imminently and very kind of acutely. So really, Aurora, to summarize my answer to that question is, patients who come in with depression, you need to explore and ask them lots of questions. That's what doctors do. They ask lots and lots of questions and they explore the issue. And then they think about ways of how they can resolve the issue, whether it be with for example, behavioral therapy, whether it requires medication. So there are lots of kind of avenues to take before that. Okay,
so basically it's just very situation dependent again.
Yeah, and I'm really sorry to kind of keep on saying that it's situation dependent, but it really, the SJTs, or situational judgment tests, the reason why you can't revise for these exams or you can't really prepare for these exams are simply because it is just a case-by-case scenario and every case is different. So you could have done 1,000 questions in the past, but the question that you have in front of you is a new one. It's a new situation, a new patient with a slightly different past medical history, and you just need to assess that in this moment in time. So it's really something to really emphasize to the examiner all the time, is that every patient is different, every patient is unique and has their own problems and past history.
Okay, thank you very much.
No worries at all. So what we'll do is we'll go on to this next slide, which I think really sums up gives you an example in terms of justice, autonomy, non-maleficence and beneficence. So Veronica, would you be able to match up A and B for me, please? So which ones do A and B match up to?
Hi, I did have a question before, but I can answer this one if you want.
Yeah, if you can answer this, and then I'm more than happy to answer that question.
Okay, so A patient is refusing the vaccination even though the doctor recommends it, and the doctor accepts the patient's decision. So I think that would be autonomy, because it's a patient's right to kind of choose what they want to do with their health.
Yeah, absolutely. And again, Veronica, this is a very kind of common type of interview kind of style question, where sometimes they will get you to maybe match something up, and like you said, you kind of gave your reasoning behind it, and that's the key. And maybe you can even pick a particular word in the two sentences here. So is there a particular word, Veronica, that resonates with you in terms of why you chose autonomy?
I think it's the part where the doctor says he accepts the patient's decision. So it's the patient's choice overall. Yeah, absolutely. And if patients make, in your opinion, poor decisions, that doesn't mean that it's you can't force them to do anything. So patients can make poor decisions. That's absolutely fine. But what should doctors be doing then in a scenario like that? If patients are about to make poor decisions, what can doctors do? I think I would just make sure that the patient really understood what they were doing. So knowing
like the benefits of doing this treatment and also the risks at the side, but especially kind of the benefits, and seeing also what their thought process is and if they've got another treatment in mind or something like that.
Yeah, no, you're absolutely right. So again, we can't force, but we can advise. That's the really kind of quote of the day, really, is that we can't force patients to do anything, but we can always advise. We can inform them and give them some information about the scenario and situation, and really ask and explore questions like you mentioned. So what about B? Which one did B relate to? And sorry, I should say lady there.
Oh, okay. So there's a polite lady with a broken arm and a rude, angry man who has hypertension and painful chest. You decide it's better to see the man first because his medical needs are more urgent, even though the lady's kinder. So I guess I see this more as kind of triaging, and you're kind of treating everyone equally. Probably, I guess it's maybe a form of justice. So you're treating everyone equally. You're still obviously trying to do good, but you'll be doing good at different times. So you'll be doing good to the man and to the lady at a later time. But maybe I think overall justice, probably, just because you are kind of prioritizing someone based off their needs.
Yeah, you're absolutely right. So it refers back to the justice being the allocation of resources and and kind of the community in general. So here, actually allocating the resources more to the person with a painful chest and hypertension. So what does hypertension mean, Veronica?
Is that high blood pressure?
Yeah, exactly. So if someone has high blood pressure and a painful chest, is there anything in particular that you might be really, really worried about? Again, this is a medical question, but is there anything that you can think of?
I'd probably be thinking of something along the lines of like a heart attack or a heart problem. Yeah,
absolutely. So something relating to the heart, but potentially a heart attack. So if you don't deal with this patient very, very quickly, then this could escalate very, very quickly as well. And this patient could potentially die. But again, you've got a polite lady with a broken arm. You know, are they going to kind of die as quickly as potentially a patient who's having a heart attack? Yeah, probably not. So nice. Do you just want to finish off with C and D then?
Oh, sorry, was that me?
Yeah.
Okay. A patient is critically ill and is unable to communicate, to give consent and treatment. Doctor decides to operate to save the patient. So I think that's beneficence, because you're just looking out for the patient's best interest and overall trying to do good for the patient.
Yeah. Absolutely. And again, very, very common scenario where, for example, patients are very, very unwell, or they might be in a coma, for example. They might have had an accident where they are actually just can't make decisions in that moment in time. But actually, for example, Veronica, if a patient comes into hospital and they're kind of unable to speak to you, and you need to kind of take some blood from them, you need to kind of put a cannula in, you aren't going to kind of, you know, you are doing something, you are putting that cannula in and taking bloods from them in their best interest. So that's really a very kind of basic example of, can you imagine a patient coming in, like say, for example, Veronica, you or I, if we didn't have capacity at a moment in time, would we want doctors to try and help us and save our lives? Hopefully we would. So that's kind of like the an example there. So doctors they've made a decision that actually we're going to do this for their best interest and to help them. So obviously, finally, D is going to be non-maleficence. But can you think of why that is?
So yeah, the doctor needs to consider the dangers of the immune rejection. So you need to consider making sure that nothing's going to really harm the patient, and it won't affect them in a way where this harm outweighs the benefits, I guess. So that's what we need to consider.
Yeah. And it's always important to remember, because we think, oh, you know, doctors, we should never do harm to anyone. But actually, there are so many complications, there are so many side effects of medications or procedures that we need to think about. And actually, this is a topic that I'll talk about in a few more slides as well, a bit more about non-maleficent in a bit more detail. But yeah, really well done, Veronica. And do you want to ask that question that you had?
Oh yeah, it was related to talking about like suicide and confidentiality.
Yeah.
If you were like in a GP practice and you had like a long list of patients waiting, and one of your patients told you, oh, they're kind of thinking about suicide or it's occurred to them, you'd probably say to them, I'll be breaking confidentiality or something. But in that moment, are you gonna like let that patient walk out of the door? What are you gonna do? Kind of.
So again, Veronica, I really want to tread water lightly here, because that's a really very kind of medical question, and we're going to this is stuff that we do as final year medical students and as, you know, F1s and F2s, answering questions like that. So it's really, really not anything that you're expected to do at all. But really, as a doctor in a situation like that, is actually we need to assess if they are actually in imminent danger. So have they tried to harm themselves in the past? Have they actually tried to act on the thoughts that they're having? So some people, when they feel pressed, for example, they think about suicide or they think about harming themselves, but actually a lot of the time they don't actually physically do anything, if that makes sense. So they wouldn't actually kind of so they might have those thoughts, but they don't actually act upon them. So those are questions that doctors ask patients in scenarios like that. But again, Veronica, I don't really want to go into too much detail there, because this is stuff that, you know, we learn on a weekly basis. So, you know, there's absolutely no way that you're supposed to know any of this.
Okay, that's fine. Thank you.
Yeah, no worries. So yeah, really, really nice in terms of the questions. That's the whole idea of these sessions. As you know, I talked last week a lot about being a proactive learner, about asking questions, about if you're not unsure about something, if you are unsure about something, you need to ask and you need to clarify that. And that's the whole point of today, is really to go through these scenarios and just clarify. If anyone has any kind of burning questions about that, then you can always just ask. So Malika and Yusuf, I'll come to your questions in a minute. Before that, I just wanted to talk a bit about euthanasia and assisted suicide. So can anyone just put in the chat, what is euthanasia? What does euthanasia mean? So what does euthanasia mean, or where might you have heard that word before? So really the definition of euthanasia is ending someone's life to relieve their suffering. So that's what euthanasia means. Now, I don't like using just the word euthanasia, because people get very, very confused about what euthanasia is. Now, there are two types of euthanasia, broadly speaking. There's active and passive. So which one is legal and which one is illegal in the UK? So just put your hand up and you can kind of answer this question. So which one is legal or illegal? So yeah, Marcel, so which one is legal and illegal, active or passive euthanasia, and what do they mean?
I would guess that active is illegal and passive is actually legal, because they're like, for example, for a cancer patient, they could decide not to have therapy or have chemotherapy and they would probably die sooner, and that, but you're still allowed to do that, as that's legal, and I'm pretty sure that's passive. But whereas actively is like maybe going somewhere to have yourself killed, and that's something which isn't actually law abiding or isn't legal.
Yeah, exactly. So active being, again, it's kind of in the name. So active is actively doing something to then end their life to relieve their suffering. So for example, actively injecting them with something that will end their life. And that's something that's legal. Now, in certain countries, that is active euthanasia is legal. So some patients, you know, there's this really kind of ethical dilemma in terms of, you know, should doctors allow patients to go abroad to have active euthanasia? Again, that's a topic to think about, I think, and think about the pros and cons and how you can discuss that with an interviewer. And again, assisted suicide is different from euthanasia, because, well, how is it different? So Jenna, how is it different? So just unmute. So yeah, Jenna, can you still? No. Or Selma? That's fine. I'll leave it in the. That's all right, Jenna. I'll just try one more time. Okay, don't worry, that's fine. So if I was to kind of summarize the difference between euthanasia and assisted suicide. So assisted suicide is helping someone to end their own life. So it's someone is ending their own life, but you are helping them in doing that. So you might provide them with some material, you might provide them with a particular medication, but they will actually end their own life. So just to be very, very clear, I want this to be very, very clear to everyone, is that passive euthanasia is, and the best example of passive euthanasia is actually switching someone's life support machine off. So people who are in intensive care and are on a life support machine to be alive, sometimes, you know, when you speak to family members and we talk about, okay, well, this patient, there's a very little chance of them having a good quality of life. So I think it might be the best decision here is to end or to stop their life support. So what you're doing is withdrawing their life support. So and that's part of passive euthanasia, and that is part of very, very good palliative care. And that's something that is absolutely legal in the UK. And assisted suicide, again, is absolutely illegal as well. So active euthanasia and assisted suicide, both illegal. So again, just to be very, very clear, so assisted suicide is the act of deliberately assisting or encouraging another person to kill themselves. Euthanasia, the actual word itself, is the act of deliberately ending a person's life to relieve suffering. So that could be deliberately passive, so deliberately withdrawing life support, or it could be deliberately active, so actively doing something. Okay. Perfect. So, again, this is a very, very common question in terms of should euthanasia or assisted suicide be legalized? Now, one of the things that I wanted to very quickly talk about here is really the slippery slope. So what does the slippery slope mean? So can anyone think in the chat, what do I mean by that? So if we allowed euthanasia to be legalized, active euthanasia to be legalized, why might that lead to something called the slippery slope? So yeah, I think there's a few common themes here in terms of this kind of snowballing effect. It could basically, a slippery slope means that if you allow something to happen, it can then lead to something else bad happening, really. So I gave a student an example the other day. You know, can you imagine if you're a head teacher of a school and if you make something like vaping, if you allow vaping to exist within a school environment, and actually that could lead to a slippery slope, because that could lead to people then thinking that smoking would be fine or other kind of illicit drugs are fine to use within school. So that's like thinking about kind of a slippery slope where if you allow something to happen, then actually that could lead to a snowball effect. And that's something that doctors think about all the time, you know, teachers think about all the time, lots of professionals think about all the time. So that's why, again, it's a really big topic to talk about with an interviewer, is this kind of slippery slope. But at the other end of the spectrum, what can someone think about in terms of the pros or the positives of active euthanasia or assisted suicide? Yeah, absolutely. It's ending suffering, I think, is the really big one, that the quality of life, the suffering, and autonomy. Yeah, you know, patients, you know, if patients have autonomy, then shouldn't they have the decision to kind of end their life whenever they like? But I think at the end of the day, you have to think about, doctors are very different from vets. You know, vets put pets down. Doctors don't do that. That's not their job. Their job is to, you know, save people's lives and to help them and to improve their quality of life where possible. So again, just a few points here just to bear in mind. So any kind of euthanasia debate or controversial topic, I'd always think about not being too strong and always giving a balanced argument, ensuring that you're thinking about the 4 ethical pillars, using case studies where necessary, or you could give some examples of your work experience, I think is a good point to put in there. And really acknowledging the complexity. This is something I would do very, very early on, actually. I would say to the interviewer that this is actually a very controversial topic and is sometimes very hotly divided, and people have lots of views on it. And that's because euthanasia is something that is so, death itself is something that is not really talked about enough. It's something that is very difficult for there to be a general consensus about what is right or wrong. And then again, thinking about the Hippocratic Oath. So why can someone think in the chat, why would the Hippocratic Oath be involved in an answer here with the euthanasia debate? Yeah, so it's really relating to kind of do no harm, do your best for patients. Absolutely, you're putting patients first. So, if your Hippocratic Oath really is stating that you should be helping patients, you should allow them to you should treat them with the utmost kind of dignity and respect. And actually, if you yourself go and kind of, I say kill a patient, then that really goes against everything that the Hippocratic Oath is all about. So why should we consider ethics? Now, this is a really a kind of open question to anyone. So I would put your hand up if you'd like to answer this one. I think we were struggling a bit with people unmuting and so I'll just try one more time. So anyone want to answer this question, just raise your hand. So Jenna, let's try one more time with yourself or Selma. There we go.
Can you hear me?
Yeah, perfect.
Okay, good. I think it's important to consider ethics because, as it says on the screen, decision making is over black and white, and you can find that as a doctor, you have to avoid being too clinical in certain scenarios, especially when dealing with patient care, which is a majority of the job. So you have to consider what's best for the patient in every aspect of the job, as opposed to just medically, because at the end of the day, they are still people.
Absolutely. And then if I've got a follow-up question then for you, Jenna. So let's say you have a patient who is quite elderly, quite frail. And so, well, first of all, what do you think frail even means, Jenna? So when you think of the word frailty, so we talk about that quite a lot in medicine. So what does frailty mean to you?
I think it means sort of fragile and being not quite resistant to a lot of things. So like issues with walking, issues with immune systems and things like that.
Yeah. That's a nice kind of summary. I think it really, frailty encompasses, if I was to sum frailty up, so what I'd say frailty is let's say you or I, Jenna, if we got an infection or if we had a certain disease, we would hopefully be able to deal with that and get back to our baseline quite quickly. But what frailty is when you get diseases or if you have accidents or incidents, then actually your baseline starts reducing quite rapidly. So what I mean by that baseline is, for example, baseline in terms of daily activities like being able to walk. People who are frail, if they, for example, have a fall, then actually their baseline really drops again, and they're very unlikely to return back to what they were able to do. So
patients become at a higher risk for things as well.
Exactly that, Jenna. So the question that I'm kind of getting at here is you've got a patient who has who is frail and also has lots of comorbidities. So again, Jenna, what do I mean by that? By comorbidities?
By what? Sorry.
By comorbidity. Have you heard of that word before?
Is it like more than one disease or condition?
Exactly.
But they have like a multitude of diseases or conditions.
Yeah, exactly. So we've got a patient here who is elderly, frail, has comorbidity, so might have multiple conditions like diabetes, high blood pressure. They might have had heart attacks in the past, for example. Now, let's say that you have this patient and they have maybe had a fall and they require some spinal surgery, and like with any surgery, there's lots of risks to surgery. So Jenna, what I'm trying to get at here is, what, as a doctor and also as a patient, what are we thinking about in a scenario like this? What are all the things going through our mind?
Especially, I think, thinking of like anesthetics, as to whether the patient will wake up from the anesthetics, as to whether the operation, either you could balance whether they end up living with the issue or it'd be worth operating. So things like that. And also sort of the stress for the patient as well, especially if they're elderly, the stress of the operation, the anxiety coming around the operation and the recovery time for the operation. There's just like a multitude of things that you have to consider. Whereas if you were looking at a younger patient, recovery time would be quicker and waking up from anesthetics would be a simpler process. So it'd be a little bit more black and white in that scenario.
Yeah, absolutely. So we've got our physical issues, so that they physically might get worse. Their psychological issues, so the anxiety surrounding kind of having a big surgery like this. And I'm also thinking about other things like dignity. I'm thinking about, you know, should a patient really be going through a big surgery where actually the likelihood of them dying or it being unsuccessful is quite high. And another thing is that's really important for patients actually is their ability to communicate and their cognition. So what do I mean by that, Jenna? So why is that so important for patients, especially when they're nearing the end of their life? Why is communication and cognition so important for them?
You could talk about when assessing a patient's capability, that they have to be able to communicate the decisions they make as well as understand it. So if they're not able to communicate whether or not they want the operation or whether they think it's something right for them, that's when things start getting a bit more complicated, because you can't really decide whether or not it's something that they actually would like. And then you could have the issue of like family members coming in, on the one hand them wanting the operation, on the other hand them not, and then it gets a bit more messy. So if they're not able to communicate their decision, I'm not actually sure what you do, but it just means that they don't really have the capability for making a decision if they can't communicate it.
So really, Jenna, it's a topic of also quality of life, and that's really something that's very, very important for a lot of patients. Is, okay, having this big surgery, yes, would it help my spine, and will it improve my spine? Well, the likelihood of it happening and being successful might be quite high, but actually the road to recovery, you know, the amount of physio, the amount of extra things that might need to be in place, their stay in hospital, you know, these are all the things that patients are considering and doctors are talking to patients about, and that is really to do with quality of life.
So the operation is worth it, and worth what's going to precede it and things like that. Exactly that. So do you see, Jenna, why, you know, the whole of today's session I've been saying, oh, everything is very case dependent and situation dependent. Do you start to kind of appreciate why that is the case? Yeah, definitely. Like I said, if you were to compare the spinal situation with a younger patient, again, case dependent, it'd be a little bit more easier to make decisions, especially if they can communicate it. So it just comes down to what they ask in the interview, I guess. Yeah, absolutely. And I've just got a paper here in front that I found a bit earlier actually, and it's again, don't need to go into a lot of detail, but the reason why I put it here is actually this study is called long-term cognitive impairment after critical illness. So I'll sum up this article. This article is saying that patients that come into hospital and are critically ill. So what I mean by that is they're going to intensive care. The likelihood of them getting cognitive impairment. So what I mean by cognitive impairment is their ability to kind of communicate, their ability to think, actually decreases significantly, and then they have a lot of issues. So the actual statistic from this paper is that about 20% roughly of, if someone can just turn their mic off, please, just getting a bit of feedback. There we go. So the article is saying that 20% of people have actually end up having issues that are so close to having a mild Alzheimer's disease. So what the whole point of this paper is just emphasizing that people come to hospital and are very, very unwell and are ill, and the likelihood of them suffering from long-term issues like cognitive impairment or having some sort of disabling cognitive impairment is very, very high. So actually sometimes it's thinking, oh, well, we need to think about the pros and cons of keeping people in hospital and actually treating them. And that's really what this paper is summarizing. So again, it's something they could absolutely give to you in the interview. So I think we'll end it there. Actually, it was a really, really important kind of discussion that we had today in terms of the topics of medical ethics. I just also want to clarify that with anything to do with medical ethics that comes up in the interview, you have to ensure that you're giving both sides of the argument and you are explaining to the interviewer your reasoning for the pros and for the cons. That really is a big take-home point. Abby, did you have a question? Sorry.
Yeah, I'm so sorry. Please, could you just go back to the youth and... Can you hear me?
Yeah, I can hear you.
Could you go back to the slides that sort of did those examples of the different pillars, please. Sorry, just so I could get that one about justice down. Thank you.
Yeah, no worries. I'll get that back up for you in a second. So is it this one?
Perfect, thank you.
No worries. Perfect. So I'll just answer any kind of final questions from today. So Shrina, did you have a question? And Jenna?
Yeah, so my question was back with the euthanasia. Would it be okay to argue a pro for euthanasia is thinking about justice? Because say if you have someone who's like sort of bedridden, like chronic depression, chronic pain type thing, terminal cancer type thing, you could reallocate resources to other conditions rather than keep spending the NHS's money on treating this person, even though they're like there's no hope for their improvement. Or would that kind of be a bit not very humane to argue in the interview?
I think, well, first of all, what I'll say, Shrina, is what do you think? What do you think about that?
I mean, it's not like a very nice thought, but it could be like a valid reason, because it could fund other treatments that have like higher chances of success to help more people.
Yeah, and the big word that you use there, Shrina, is could. And that's a really important word to use, actually, that telling the interviewer that actually some people might say, or some people could argue that this is the case. And that's absolutely fair enough. You know, you can give that as an argument, and you can say that, you know, some people could believe that this is, you know, well, basically everything that you summarized there, Shrina, in terms of, you know, allocation of resources. You can say that some people would argue that euthanasia should be legal, it should be absolutely legal, because that allows a better allocation of resources. However, personally, I think that kind of goes against certain principles that doctors abide by. Yeah, so it's thinking about that type of argument.
Yeah.
Yeah.
Okay, thank you.
Perfect. So we've just gone over time, so we have to stop there. If you've got any other questions, I can answer them next week, or you could always email us as well at our MedicMind email. I really appreciate everyone joining today. I hope you really found it useful, and I'll be back next week for another session on Sunday. But yeah, any kind of issues or problems, then you can always just email us or ask us next week. But no, thank you very much, everyone. Take care. Have a lovely rest of the evening, and I'll see you all next week.
Thank you.